hopefully now. Okay, that should be better now, though. Okay. There we go. Okay. Sorry about that. So we should be good now. So, okay. Go over HNS versus DKA. So, when it comes to hyperosmolar, first thing we look at is the blood sugar levels, and we'll look at it with so blood sugar is going to be usually around 400 or less than 400. You're not going to have very, very high glucose levels with DKA. With HNS, it's going to be very high, over 400 for sure. It can even get up to, 1,000 in some patients. Very, very, very high sugars in the blood. The next thing we're going to look at is the pH with regards to DKA. Because they're in ketoacidosis, we know they're going to be acidotic. So pH will be less than 7.25, 7.3 in that area. I'll put 3. 5. And pH will be normal, relatively normal with hyperosmolar because they still have a little bit of that insulin left. So they're not going to have any problems with the developing ketosis. Next, we can look at anion gap. They're going to have an anion gap here because of all the ketones floating around in the blood. So you're going to have this anion gap. With hyperosmolar, they have relatively none to little anion gap. They may have a very small one, but for the most part, they're not going to have any anion gap with regards to the hyperosmolar. Let's keep going. Let's talk about ketones. Mainly in the serum, because remember, we don't really care about the urine so much. Yes, they're going to have ketones in the serum. Most likely not very low in the for ketones for hyperosmolar. Okay. So I hope that helped answer that question regarding the hyperosmolar versus DKA. The big thing for both of them, treatment, is the same. One is always going to be fluids. You got to hydrate them like crazy. They have a really bad osmotic shift going on with all this glucose. 2, insulin. We give them insulin. Get that sugar down the rest of the way. Once we give them fluid, it's going to dilute out the level of the glucose and help bring it down that way as well. Make sure you also know with regards to fluids and regards to what is the normal drop that you want to achieve in glucose. So we went over that in that complications lab. What's that normal drop? How you don't want to go too fast. If you go too fast, what are you going to cause? The cerebral edema, potentially pulmonary edema, if you lower the glucose too fast. So fluids, we load them with fluids. Next, we give them insulin to help. Again, they need insulin, whether they're in DKA or they are in hyperosmolar. They're still going to need insulin to get all that sugar back out of the bloodstream into the liver, the skeletal muscle, or the fat. So the insulin's going to go the next of the way. Most of the time, it's going to be in an infusion pump in the ICU for these patients. They don't go to a normal floor. Once you give an insulin, we have to be careful for potassium. Remember that when we give insulin, it's going to drive potassium into the cell. So we have to be very careful with potassium because we're giving them all the insulin. So remember, if the potassium is greater than 6, we don't have to replete the potassium. Then as you go down the ranges, you don't have to memorize these things. But again, as you go down the next level, K is less than 5, I think it was 5.6 or something like that. Then you give 10. The next level down, you just give 20 milliequivalents. And if they have very, very low potassium, you may want to hold off on that insulin depending on how low it goes. So that's the third treatment for hyperosmolar and DKA, is watching out for the potassium. The fourth level of treatment is the bicarb, but only really if they really are suffering from like the renal acidosis where they need the bicarb, or you just start really destroying those kidneys with the acidosis going on. So bicarb, if they need it, not to address the acid base so much, but if they need the bicarb. And then finally, the last level of treatment, again, if they need it as you go through your treatment plan, is any antibiotics if they're having any sort of underlying infection, especially those DKA patients. They may have an underlying infection that triggers their whole cascade of events. Hyperosmolar patients, antibiotics. We talked about how the risk for that, especially in the elderly, is that they live in the SNF facilities. And so they need all that extra care. So those are the 5 steps in order: 1, fluids; 2, insulin; 3, potassium replacement; then bicarb if needed; and then antibiotics again if needed. For the next question regarding labs, all 4 are needed. Usually, yes, you're going to see all 4 of those will be changed like that. And the bicarb being low is just because of the acidosis trying to buffer it. You don't need to replace that once you correct the acidosis or the underlying glucose being the issue. The acidosis should self-correct itself, and you don't have to worry about the bicarb. That's why you have to be very careful with the bicarb. You may raise the pH too much by giving too much. Also remember the key numbers. Let me just get this bigger. And the 200. So this is your fasting plasma glucose, hemoglobin A1C, random plasma glucose, meaning they're having symptoms of diabetes and you do a random check and they're 200. Or the other side of this is your 2-hour oral glucose tolerance test. After 2 hours of giving that sugar load, you should be below 200. And these are the 3 things. On this side of the number line, prediabetes. If you're on that side of the line, you are diabetic. Be right back 1 second. Okay. Now, there were some questions also regarding like sliding scales and coverage scales and things like that. I will tell you exactly what the scale is. You just have to know how to read it. So I might say in a question, the patient's preprandial is 270, and I may give you a scale with just tells you exactly what your prandial is and the insulin. So if they're, I'm making this stuff up. So if they're 150 to 200, you give 4 units. If they're 200 whatever, to 250, you give 6 units. 250 to 300, you give 8 units, and then 300 and above, you give 10 units. So if I say their fasting preprandial is 270, you know they need 8 units to cover the preprandial glucose. So they need 8 units for that, plus whatever your coverage is for your carbohydrate in your meal. And this number together total at a meal. That's how you get your thing. When we did in class that the total daily dose at the class 1 was 36 units, international units per day, and we know they have to take 18 units for basal, and then 6 units, 6 units, and 6 units for breakfast, lunch, and dinner. This is an estimate. This is exact. If they use this one or this one is up to patient. Whatever they're more comfortable with and on, it's fine. I will give you the conversion for the total daily calculations for insulin. I'll give you all the conversions you need to know. I won't. So on the conversions, I won't give you the scale like this. I'll tell you exactly that they are insulin naive, so the conversion factor is 0.3 units. I will give you that information. I'll tell you exactly what the conversion is. I'm not going to make you just guess based off of their BMI and stuff like that. Meds we can start giving with metformin when they're not at goal. So remember, metformin is the first line therapy. Depending on how severe that A1C is, if it's creeping up around that 9%, we will add insulin to that. If that A1C, is less than 9, but they're not really at goal, add glyburide. If you are in primary care, your goal is just to try and get as much as you can done here. Get some work done here because these are still PO meds. Once you start dealing with insulin, you send them right to endo, and endocrine will take care of all the diabetes management. If you have a great interest in diabetes and endocrine, we have a great clinical rotation in endocrine. You'll start seeing a lot of the other things. Obviously, when we get to the other unit in endocrine, we'll get to all the other diseases, but we have a great clinical rotation in endocrine. We actually will see all these things, and actually we'll see patients that have these problems and how they act, and the complaints that they have, and how they take care of themselves and whatnot. You'll be taking care of that a lot more. Any other questions? So let me pull up the slide. I don't want to say anything wrong here. I know glyburide was used later, but I'm sorry, it's not glyburide, it's glimepiride. That's one of the older ones. Which is the only sulfonylurea that's approved for use with metformin or insulin, so that's why it's a second one. I remember the big things that we talked about as far as the side effects, like the TZDs with regarding don't give them with heart issues. Most of them are obviously heart problems. A lot of the stuff on this block is also a lot of like patient education, just because it's just, a lot of it is just talking to the patient, make sure they're at their goals, make sure you understand the LDL and the blood pressure goals. For risk stratification, if they need aspirin or not. So with follow-up, if they're not on any medication, you can definitely go 6 months. If they're on medication at first, you want to be every 3 months. Then you can go every 6 months if they're on medication. If they're on insulin and they've been on insulin for a long time, then you could probably go 6 months, but I wouldn't go any longer than that to see a diabetic patient, especially if they're on insulin. If they're not on anything and they're just lifestyle modification, 6 months to a year, see how they do. Now, when we have that example in class of that one patient who, over a year, 2 years, you think about, if I see a patient today, it's February, and they're borderline diabetic, I'll see them back in, 6 months, see what's doing. That's 6 months from now. Let's say they are diabetic then I'm going to see them in 3 months, but you may not see them exactly in 3 months, maybe 4 months before you see them. And then by the time you see them again, then maybe another 4 or 5 months before you see them the second time. So time just stretches out, and before you know it, it'll be like a year, and you would want to see them 4 times, but maybe you only saw them 3 times that year because of just scheduling and this and that. Things happen. So we're trying to ramp up your medications, and it may take a while before things happen. So that's why you want 3 months for uncontrolled, knowing it may be 4 months before you see them. those 6 months may turn into a year before they come back. So that's why, just get them on the books for 3 months and then go from there. You're not going to have any problems by seeing your patients more often, especially if they're a diabetic, even if for a lifestyle check. So for those, the Dawn phenomenon and the Samogi phenomenon, both of them you would just you can lower the basal insulin, or you can go to an intermediate dose and do twice a day. You can do both. It's either one. Let me just pull up what I said though. That's in complications. I wasn't a type 2 one. Look at my notes. See what I wrote. There we are. Yeah, so both of them you can switch to intermediate. So every exam that we give will always have the brand and the generic, unless it's something like everyone like amoxicillin. I don't know if there's a brand name for amoxicillin, but we will always give you the brand of the generic. That's in all exams in PA school. Okay, we'll go until a few more minutes. I know this material is very straightforward, not as dense as most of the material we've covered together. Kind of gets easy on the way out. Two more weeks. That's correct. So if they're type 2 diabetic and their kidneys are okay, yes, they're going to benefit from that high protein diet. Just, you know, just due to the blood sugar response. You're going to have a night gradual increase with a nice protein diet, whereas if you didn't, you might have a big spike. We want to avoid that. But if they have kidney damage, we avoid protein mainly because it has to go through the kidney to get metabolized. And if you overload the kidney when they're already damaged, you're going to, really do some damage to the kidneys. So that's why if they have kidney damage, we kind of be careful with the protein just because of the kidneys itself having to deal with the protein molecules themselves. Not because we're trying to avoid anything with the diabetes. It's more just the kidney damage. Okay, any last questions? Okay, I don't see any more questions or anything, so I'm going to call it for the night. Thanks for being forgiving with the time delay. Oh, here we go. Kidney damage. Will we look more at? So remember the markers of kidney damage. You could use BUN and creatinine. The better way is the estimator that you'll get on the lab printout is the GFR. That's the better way to look and assess kidney damage. When they get less than 60, that's when you start worrying about stage 2 kidney disease and I'm guessing issues from there. But yeah, that's how we look at kidney damage. The looking at the urinary microalbumin is looking at assessing the damage. So you could have a GFR of 55 in one person and no protein, and you have another person with like, that's a bad example. GFR of like 40, 45 may have very minimal protein, and then another person have a lot more protein in the urine with a similar GFR. They probably get a little more damage, so that you see a little more urine, the protein slipping through and going in there. So GFR is a great thing to do all the time because it's just blood. It's not all the time you do a urine dipstick to see what's going into the urine, but obviously in an endocrine office and if you're diabetes patients, then you need to like obviously do urine dipsticks to see what's going on. Yeah, so the microalbumin is the little bits of protein. Like remember, no protein should ever get through those sieves in the renal system because of the podocytes and then obviously the electric charge. So if the kidneys are being damaged, that sieve is getting bigger. Now those proteins can start getting through into the urine, and you'll start seeing that on that urinalysis. It's just that it's not a routine thing unless they're diabetic and you're in an endocrine office. Then obviously you will be doing dipsticks all the time, and in those renal offices. So protein should always be 0 in the urine. You should never have any proteins in there. But when you start seeing the proteins, those albumin proteins, that means there's kidney damage going on. It could be acute kidney damage. It could be chronic. So remember your acute chronic renal failures. You're not going to need to know it for now, but you're going to get it up with they'll do it in nephro by. So Dr. Wood mentioned the basal dose can be split in half, with one half taken before bed, the other half taken when they wake up. It's fine. You can do it that way. You're just going to have the basal dose. It'll stay in your system still for the 24 hours, but at least you're not getting a big bolus of that basal dose all at once. And that's what you're trying to avoid. But you can do that. Advantages would be maybe saving money because you're not having to buy a different preparation. And although you are probably going to use more needles, but maybe if you get an insulin pen, maybe it won't be so bad. The joys of juggling insurances when you get to practice. So. But I wouldn't make a test question that confusing where I would say, someone's having AM hyperglycemia, you think they have Dawn phenomenon. Um, what would be the treatment? I'm not going to say split the basal dose in half or change to intermediate and do it twice daily dosing. Like that's too ambiguous of a question. Those two overlapping. I wouldn't, do it like that. So. Any last minute questions? Okay. I think that's it then. We'll call it. You guys are welcome. I will see you all bright and early in the morning for the exam. Have a great night and see you then.